Hello, so today we're going to talk about chapter 49, which is the normal first trimester. So we're starting our obstetric chapters now. I'm not going to go over all of the slides. I want you to be able to read your book and review these slides because there are going to be things that I don't cover today that I do want you to be aware of. So let's talk about just the overview of the first trimester. Terminology is embryologists state the state time and conceptual age, also known as embryological age. So conception of the baby is the first day of pregnancy when it comes to embryologists. However, with doctors and sonographers and clinicians, we use gestational age, which is also known as menstrual age, to date the pregnancy. So this is from the first day of the last menstrual period, is the beginning of gestation. So technically, from what we use as gestational age, the first 2 weeks of the pregnancy, you're not actually pregnant. The reason that we do this is a lot of people are able to track conception easier from the last menstrual period than the exact date that they conceived. So people tend to know when their last menstrual period was, but they don't tend to know exactly, well, when did you ovulate? When could you have conceived? That's really hard to, determine. So it's just easier for us to use the last menstrual period. So that's what we use is gestational age. So technically, 2 weeks of the pregnancy are actually, you're not pregnant. And that's just basically what I said. So gestational age adds 2 weeks to conceptual age. 12 days after conception during the implantation process, the conceptus is known as a zygote. From the time of implantation until the 10th week of menstrual age, the conceptus is known as an embryo. You'll need to know that for your test. And after 10 weeks, an embryo is called a fetus. During a 28-day menstrual cycle, the mature ovum typically is released on day 14, which we've learned about. Now, if you remember, the first phase of the menstrual cycle is proliferative, and the second phase is the secretory. A person ovulates around day 14. So, that's about and when conception will occur, about a couple days after that. The ovum is swept into the distal fallopian tube via the fimbriae. You remember that's part of the fallopian tube, and the little finger-like projections, and fertilization occurs within this region 1 to 2 days after ovulation. The follicle that released the mature ovum hemorrhages and collapses and forms the corpus luteum, which you guys remember that. And this begins to secrete the progesterone and estrogen needed for the baby. So here's just a picture of this. So this is the mature ovum. This is if you ovulate around day 14. And then the little ovum is swept up into the fimbriae, and it meets up with the sperm, and fertilization occurs usually in the fallopian tube in the ampullary part. Then it travels and it makes its way down here. It becomes a zygote, keeps dividing as it makes its way down to the fallopian tube. And then in normal pregnancy, it usually makes it down to the endometrium, becomes a blastocyte, and then eventually implants into the uterus. So trophoblastic cells begin to secrete the human chorionic gonadotropin absorbed within the tubes and stimulates the maternal pregnancy response. This tells the HCG tells the corpus luteum, hey, there's something going on here. You need to continue to secrete your progesterone and estrogen. The HCG is also what is detected in a pregnancy test. The blastocyte typically enters the uterus 4 to 5 days after fertilization. So the implantation into the uterine decidua completed within 12 days after fertilization, usually around a little bit before the missed period. And it just starts, it hopefully has a really nice thick endometrium to implant into, and it starts eating into the decidual tissue, I guess there's not a better way to put it. And it just digs right down in there. And this is when the blood exchange occurs. So it occurs so early, like even potentially before a patient has missed their period, you know, there's, you know, a little bit of blood exchange starting. Sometimes a patient will have implantation bleeding around the time of their missed period, and the process sometimes results in light vaginal bleeding at about the same time, just like I said. When implantation complete, trophoblast has formed primary villi, which initially encircle early gestational sac. So some patients say, well, I had a period, and so they don't believe that they are pregnant because they actually have blood about the time of their menstrual period. Maybe it's a little bit lighter. But what they were actually experiencing was implantation bleeding from the trophoblast implanting into the endometrium. So that can screw some people up, get them confused. At approximately 23-day menstrual age, a primary yolk sac is pinched off by an extra embryonic celome and forming the secondary yolk sac. So I will show you what a yolk sac looks like. What we'll see and what we need to identify on our first trimester scan is a yolk sac with the baby, because that hints that the pregnancy is normal. And what we're seeing actually is a secondary yolk sac when this occurs. So that might also be on your test. You also have amniotic and chorionic cavities that are developing around this gestational age. Okay, so this is a pretty early pregnancy, I would say. Okay, so here's the uterus, it's like a transverse. This is the endometrium. This little line right here is that there's like an extra ring of echogenic material around the gestational sac. That's a really good sign that the pregnancy is developing normal. It's called the decidual reaction. There's this little black area right here. This is the gestational sac, the small gestational sac. And this little area right here, this little circle, this is what we call a yolk sac. And this is going to be the first thing that develops. Even before we see embryo, we will see the yolk sac. And I would say at this stage, from this looks about, this would be about a 5-week gestation. So the embryonic phase is between week 4 and 10. During this phase, all the major internal and external structures begin to develop. This is such an important time for the baby. A lot of things are developed in this first trimester. So it's very important, if you decide to get pregnant someday, that you're just very, very careful when you are early first trimester. Make sure that you are taking care of yourself and not doing anything silly, because this is when all the good stuff occurs. Brain, the limbs, the heart, like everything starts developing so early on. The cardiovascular system undergoes rapid development, with initial heartbeat occurring between 5.5 and 6 weeks gestational age. So technically, this will be on your test, guys. You need to know 5.5 to 6 weeks. So technically, the embryo is from the embryonic age. The embryo is only 3.5 weeks when it starts having a heartbeat. Isn't that crazy? Gestational age, when how we measure it, because we add those 2 weeks, the last menstrual period is 5.5 to 6 weeks. And so that's how I want you to know. But I just want you to be aware of how early on a heartbeat starts on these little babies. So the embryo appearance changes from a flat disc-like configuration to a C-shaped structure. Then it develops more human-like appearance. And they're really super cute when they're like 8 to 9 weeks. They have like little limbs flapping around. They're adorable. During this period of embryogenesis, the crown rump length, which is the measurement that I want that I'll be teaching you guys, develops rapidly, measuring about 35 millimeters by the end of the 10th week. So the baby is developing so fast. So first of all, what you're going to see if you were to scan a little, let's say 6-week fetus, 5 to 6 week little embryo, this is what it's going to look like. It's just going to look like a disc-like structure, but you're going to see like a heartbeat in the middle. So you would measure the crown rump length from one edge to the other edge. That's how you would measure, and it would calculate gestational age for you. Then about 6 weeks, they start like looking a little bit more human, 6 to 7 weeks, and they kind of look like a C-shaped structure. And this is how you would measure the crown to rump. Then around 8 weeks, look at them. They're starting to get those little limbs. It's starting to look a little bit more human. And this is about, I'd say 8 weeks, and you would measure from top of the head to the little booty. Then can you believe it, guys? Just by the end, probably around 11 to 12 weeks, they look at their cute little fingers in their hands and their feet. It's just amazing how much they develop in the first trimester. And they look like a little human. And so you would measure from crown to rump. You would not measure the legs. The last 2 weeks of the first trimester, the weeks 11 and 12, constitute the beginning of the fetal period. So during the fetal period, there is a continued growth of organs and structures formed during the embryonic period. At this stage, fetal head is disproportionately larger than the rest of the fetus, constituting 1/2 of the crown rump length. Just like, look how big that head is. It's almost as big as the body. Here's another cutie. This cutie is probably about 11 to 12 weeks old, looking at and waving at us. You can see even this profile picture, you can see the nasal bone is already developed, the little sweet mouth and the chin. This is the booty. This is the head. So you would measure for your crown rump length from the top of the head down to the booty, down to the rump. As the fetus grows, the body growth accelerates and disproportionately becomes less pronounced. So the body kind of grows more, and so the head isn't as huge. But fetal anatomy fully developed in the late first trimester. So it's difficult to see, but if there is something very severely wrong, we can usually see it at the end of the first trimester. All right, so there's some maternal serum analysis that we can do in the early pregnancy that would help a patient if they had a high risk of trisomy 21 or wanted to know if they have a high risk of trisomy. There's these tests that aren't that can give them a risk update. Now, I don't want to go over this too much now because we will go over this later on in OB2. But just to let you know, this is called, and there's a couple of different screening tests. There's a nuchal translucency test, which we kind of talked about a little bit, I believe, where we measure the back of the neck here, this little area, and you want it less than 3 millimeters. And that is correlated with blood work. And then it gives a risk analysis of how likely that fetus is to have trisomy 21, trisomy 13, or trisomy 18. One thing I did want to point out And this is that ectopic pregnancies, if you remember, ectopic pregnancies are pregnancies that are outside of the uterus, usually in the fallopian tube. They don't make it all the way to the uterus. They demonstrate a lower HCG level than intrauterine pregnancies. So when a patient comes in and we can't see a gestational sac or yolk sac, but it's pretty early on, they'll do HCG levels, they'll do blood work, and they will watch that blood work to see if the HCG levels increase respectively. If they increase less than they should, it could be an indication that this is an ectopic pregnancy, and it probably is not a viable pregnancy. So a normal gestational sac is usually seen and be able to be demonstrated when the HCG level is around 3,000. The normal IUP, intrauterine pregnancy, less than 7 weeks, demonstrates doubling of the quantitative maternal serum HCG levels every 3.5 days, or an increase of 66% in HCG levels within 48 hours. So I want you to know that for your test. If this normal rate of increase is not seen, there's a greater chance of an ectopic pregnancy. Abnormal pregnancies tend to demonstrate lower HCG level relative to the gestational sac development. So even if the baby is not developing correctly, sometimes those HCG levels are lower than they should be. Here's the HCG levels for menstrual weeks. So look how much they increase from 5 to 6 weeks. There's a huge range, 7,000 to 230,000. At 9 to 10 weeks, the HCG levels plateau and subsequently decline while the gestation continues to grow. In pregnancies where a fetus is trisomy 21, which is a Down syndrome fetus, the HCG levels plateau later and fall much more slowly. Increased HCG levels can be used as a screening marker for Down syndrome during the first and second trimesters. And the HCG is component of the first trimester risk assessment and component of the triple screen, quad screen testing performed during second trimester. These are all blood analysis tests that can give a patient a risk of having a Downs or trisomy 1813 baby. Both the total HCG and free beta HCG is used for aneuploidy screening in the United States. Also, what is used is a PAP-A, pregnancy-associated plasma protein, and it is going to be initially lower than in normal pregnancy. So the HCG level will be higher with trisomy 21, but the PAP-A will be lower. So the PAP-A analysis at 9 to 11 weeks of gestation age is the strongest biochemical marker for Down syndrome, but it's not sensitive enough. So they also need to look at the HCG levels and the sonographic markers, which is the nuchal translucency, to make it a combined screening and give a better risk assessment. We also are doing now a lot of free fetal DNA tests, which that has a pretty high detection rate for trisomy 21. trisomy 18 and trisomy 13. And a lot of patients are doing these now. One of the interesting things about doing this test is you can also determine the gender at this time. So patients are finding out around 11 weeks what they're having from their blood work. So a lot of people like to find that out. Okay, so the major components of the routine first trimester examination. So this is what you're going to be doing when you're doing a scan on a first trimester patient. You're going to look at the uterus and the adnexa like you would a regular gynecological exam. Then you're going to measure the embryo. You're going to look for the presence or absence of cardiac activity. That's the first thing that I usually do. You're going to make sure there's only one or two in there. So you'll look at the fetal number, and then you'll look at the adnexal structures. And if the baby is around 11 weeks, 6 days to 11 weeks to 13 weeks, 6 days, you might be able to do a nuchal translucency exam if they want you to do that. During the 5th week of embryonic development, the intrauterine pregnancy can be visualized sonographically, so you'll need to know that. And it appears as a 1 to 2 millimeter sac with an echogenic ring, which is that decidual reaction. The anechoic center, it represents the chorionic cavity. The circumferential echogenic rim, which is the decidual reaction, is seen around the gestational sac, and that's represents trophoblastic tissue, and that's very good to see. So this is an image of that. This is the end of the 2nd month and end of the 3rd month. You can see the total difference in just 1 month. Typically, the gestational sac is fundally located. And this is what I'm talking about when I'm talking about the decidual reactions. This is a very up close look at the endometrium. This is the uterus here. This echogenic area right here is the endometrium. Then see this even more echogenic ring around the black area? This is the decidual reaction. And this is a very, very, very small gestational sac, about 5 weeks. The normal sonographic feature of a gestational sac is a round or oval shaped, fundal position uterus, eccentrically placed position in the middle portion of the uterus, smooth contours, and a decidual wall thickness of greater than 3 millimeters. This is another picture, and you can see that it is fundally located. You can see this nice black gestational sac. You can see this echogenic ring around that. That's the decidual reaction. Implantation in the lower uterine segment may be associated with placenta accreta or placenta previa. Yolk sac should be seen when the mean sac diameter, which is the measurement of the gestational sac, is greater than 12 millimeters, and an embryo should be seen when the mean sac diameter is greater than 18 millimeters. So measuring the mean sac diameter is basically measuring this from here to here. I like to do a triple caliper measurement. So I'll take the gestational sac and along, transverse, and width, length, and it will give me my mean sac diameter. So what are the sonographic features of a normal gestational sac? Well, it can be round or oval. The position should be in the fundal or middle portion of the uterus. It'll be smooth contour. The wall will be echogenic. And the internal landmarks, the yolk sac present when gestational sac is greater than 12 millimeters, and the embryo is present when the gestational sac is greater than 18 millimeters. So the growth is 1 millimeter per day. So you need to know these features. Oops. Sometimes I change this to make it pretty, and then the text gets overlooked. So sorry about that. in your notes, it is not like this, so it should be easier to see. So the yolk sac is seen before the beating embryonic heart, which I talked about. The yolk sac is the first thing that you see after the gestational sac, but you should see the embryo around 5.5 weeks with a heartbeat. So between 5.5 and 6 weeks of gestation, the amniotic cavity, membrane, chorionic cavity, yolk sac, and embryo should be seen. The yolk sac is the earliest intragestational sac anatomy, normally seen from 5 weeks of gestation. It functions by providing nutrients to a developing embryo, and kind of does what the placenta does until the placenta takes over around 12 weeks. The yolk sac is initially attached to the embryo via the yolk stalk. But around 8 weeks gestation, the yolk sac kind of separates from the embryo and detaches from the yolk stalk. So you'll see the yolk sac separate from the baby. So this is what I'm talking about here. So early on, the yolk sac will be very close to the embryo. But as the baby gets older, the yolk sac is separated and kind of is over on its own space. Usually disappears around 12 weeks, I think. Visualization of the yolk sac predicts viable pregnancy in about 90% of cases. So that's like a pretty big deal. Seeing the yolk sac is a very good sign. Failure to visualize the yolk sac with a mean sac diameter that is greater than 12 millimeters is suspicious for abnormal pregnancy. This is a very small yolk sac. This is a 6-week gestation. Growth rate of the yolk sac has been reported to be approximately 0.1 mml growth of mean sac diameter. So it grows with the sac. You will not need to know that part. But what I do want you to know is the normal diameter of the yolk sac should not exceed 6 millimeters. And large yolk sacs tend to happen when something's not chromosomally normal at the baby. So this is a very large yolk sac. Usually when I see a very thin, large yolk sac like this, it's not a good outcome. Number of yolk sacs is consistent with the number of amniotic membranes. So if you see 2 yolk sacs, you have a pretty good chance that this is a twin pregnancy. So in twin pregnancies, 1 yolk sac with 2 babies is a monochorionic monoamniotic pregnancy. When you have 2 yolk sacs, it's usually a diamniotic monochorionic or diamniotic dichorionic pregnancy. We will learn more about that later on, so don't worry about that right now. Typically, the yolk sac resorbs and is no longer seen sonographically by 12 weeks. It's done its job because the placenta really starts taking over, and so there's no need for it anymore. Okay. Now let's talk about the embryo. At the beginning of the 5th week, there's a little bilaminar embryonic disc, which we kind of looked at in that one picture. And so that's how you're going to see the little baby around 5.5 weeks. Then organogenesis begins. Early embryo often not identified until the heart motion is detected, approximately about 5.5 weeks. An embryonic heartbeat must be seen in a living embryo when the crown rump link is greater than 4 millimeters. At this stage, the embryo is seen between the yolk sac and the immediate gestational wall. So they're very, very close together. And this is what we're talking about with that. So there's just like this little disc, like a little pole, fetal pole is what I say. And then it's really close to the yolk sac. And this is about 6 weeks. This one's 5. So it's very small, but in the middle you will see flicker of a heartbeat. So that's one way of really identifying the fetal pole. As the pregnancy progresses, the amniotic cavity grows and the corresponding space between the embryo and yolk sac increases, which we saw. There's an amniotic membrane, and then there's a chorionic cavity, and they are separated. The chorionic cavity may appear sonolucent, and increased overall gain settings may fill fluid with low level echoes, while the amniotic cavity is more sonolucent. So this is what we're talking about here. So this is the amniotic cavity that is surround the baby, and it's nice and clean. And then the chorionic cavity is more like, has some internal echoes because it's kind of like a dumping center for the baby until, again, the placenta takes over. Yep, that's what I said. Chorionic cavity is initial dumping ground for the embryonic waste. Later, placenta takes over the process of waste removal. And the chorion and the amnion fuse around 14 to 15 weeks. So you won't see that separation when you do a second trimester scan. This is just showing another fetal pole. I'm going to skip over those. So like I said before, the time between the 4 and 10 weeks is the embryonic period. After that, it's the fetal period. The embryonic cranium and spine develops early on, around 6 weeks. This is a 8-week spine. There is a figure in your textbook that kind of goes over the embryonic development of the brain, which is pretty interesting that it's developing so early. This is a 3D image of the cranium and abdomen of the baby. This is around 7 weeks. Now, what I really want you to know is that the cystic area right here in the brain is called the rhombocephalon, and that is a normal appearance and a normal thing that happens in the brain. So that's not abnormal to see that. You actually want to see that. This is another image. So you can see the brain developing here. This is the head, and this is the rump. And then this is the fourth ventricle of the brain, that anechoic area. It's okay. The rhombocephalon divides into 2 segments, the cephalic and caudal portion. You don't need to know that. You just need to know that it is a cystic structure that is in the brain in the first trimester, and it is a normal thing. By 9 weeks, the midline falx is formed in the brain, which is really interesting, and you can actually see the choroid plexus tissue. So it's just crazy how fast you can watch the brain develop. The lateral ventricles you can also see in the late first trimester. So this is top of the head here. It's like a transverse head. These are the choroid plexus. This line right here is the midline falx. So all that's already starting to develop early on. And further evolution of the cerebellum, medulla, and medulla oblongata encloses the rhomboid fossa at around 10 weeks. So that's just a little bit about the brain. The limbs also are my favorite because they're just so cute. The upper limbs form first and followed by the lower limbs, and you can see them flapping around 8 weeks. The hands and feet develop around the 10th week of gestation. This is at 6 weeks. You can see the little early arm. Sonographically, the limb buds may be detected around 7 weeks. Calcification of the clavicle begins at approximately 8 weeks. Mandible, palate, vertebral column, neural arches, frontal cranium bones, they all start calcifying in the embryonic period. Again, this is stuff that you won't need to know for your test, but it's just good to know what is happening in the first trimester. This is the calcification of the bony palate here, but also you are looking at the nuchal translucency that they're measuring. And this baby is probably about 12 weeks. Now, one thing I do want you to know is that there is normal physiological herniation of the bowel. The anterior abdominal wall is developed about 6 weeks gestation, and the primitive gut forms simultaneously as the dorsal yolk sac incorporated into the embryo. So the midgut develops, then the small bowel, cecum, ascending colon, and proximal transverse colon all develop. As the amniotic expansion occurs, the midgut elongates faster than the embryo is growing, causing the midgut to herniate out of the umbilical cord until approximately 10 weeks gestation. So let me show you. This is a 3D image of the herniation of the bowel. So you will see like a circular area outside of the baby, which is a totally normal echogenic mass. And that's just the midgut developing because the abdomen hasn't caught up yet. And then it goes away usually around 12 weeks. The embryonic heart, I want you to know that it starts beating at approximately 35 days, which is 5 to 5.5 weeks. And at first, it's an endocardial heart tube fused to form one single heart tube. By the end of the 8th week gestation, the heart has obtained its adult configuration, so it has 4 chambers. The embryonic cardiac activity should always be seen by 46 menstrual days or when the crown rump length is greater than 4 millimeters. I want you to know that. I want you to know the rate is 90 to 115 beats at 6 weeks, so it starts out slow, but can increase to rates 140 to 160. I've even seen it at 180 around 9 weeks, and that's okay. Then it usually goes around 140 for the rest of the semester or trimester. So this is the gestational age again, and this is the mean fetal heart rate for each stage. There are 2 ways to determine gestational age, and there's the gestational sac size. What happened is what we can kind of determine when we can't see an embryonic embryo or a fetal pole yet, or the crown rump length, which you measure the baby from head to rump in the first trimester. The mean gestational sac size correlates closely with menstrual age during the early pregnancy. And the size remains accurate through the first 8 weeks. So it kind of increases. You can get a pretty accurate gestational sac size determination of what gestational age it is. When you measure the gestational sac, you want to measure the black, but you don't want to measure the echogenic ring around the gestational sac. This is the mean sac diameter, length, width, and height divided by 3 is the MSD. The crown rump length is very accurate, actually. It can be obtained around 5.5 weeks during transvaginal sonography. And crown rump leads are considered most accurate method for dating through 12 weeks of gestation. This is talking about the first trimester risk assessment, which we kind of talked about earlier on. But I'm going to have you look through those notes on your own. I do want to show you that this is a really cute picture of a baby around 12 weeks. But what we're looking at here, this is the amnion sac. And this is this little area back here on the back of the neck is the nuchal translucency. And so this is where we would measure to get our nuchal translucency measurement, and then they correlate it with blood work, and that gives the patient a risk assessment of what are the odds of their baby having a certain trisomy. Usually, if it's less than 3 millimeters, it's good. The larger the NT, the higher the risk. So these are the criteria for measuring the nuchal translucency. You want to see the nasal bone. That's another thing that they will ask in the nuchal translucency form. Do you see a nasal bone? See, this is the nasal bone right here. This is the tip of the nose, that's the nasal bone. Here, we don't see a nasal bone. Well, the reason why this is an important thing is that there's about half of babies with Down syndrome don't have nasal bones. And so not being able to visualize one goes into the risk factors, into the risk algorithm, excuse me. Small nose or mid-face hypoplasia are well-known components of the Down syndrome phenotype. And we'll talk all about this in next semester, which is one of my favorite chapters. It's just so interesting. Okay, a lot of the times multiple gestations are also diagnosed in the first trimester. That's when most people find out that they're having more than one baby. Overall, twin gestations have 7 to 10 times greater mortality rate than do singletons, so they're a higher risk pregnancy. But there's going to be more to talk about later on with you about that. So I guess that's it. I know this was a long lecture, but I hope that you will read your chapter, do your workbook, and go over this and go over your PowerPoints. And if you have any questions, just make sure to write them in the discussion or email me, and I'm happy to answer or do my best to answer your questions to my best of my ability. Okay, you guys have a good day. Bye-bye.